Hey everyone, welcome to this episode of Practitioner Spotlight. Today I am talking to one of our very top guys. This is Dr. John Campione. Welcome, John. Thanks for giving us your time today. Why don't you
Hi,
just
Dave.
tell us a little bit about yourself, what you do, where you're at, and we'll go from there.
Well, thanks for the opportunity. Like you said, my name is Dr. John Campione. I am a chiropractic physician. I practice in Warrenville, Illinois, which is right outside Chicago area. Graduated from National University of Health Sciences with my Doctor of Chiropractic, my bachelor's in exercise physiology from West Virginia University. I specialize in what most people would refer to kind of as physiotherapy. Being board certified in physiotherapy in this state, and really specialized in physical rehabilitation, movement dysfunction, and I like to say I take a very neuromusculoskeletal approach to every case that really comes by. So I see a great deal of the weekend warrior types, those people that are getting more active, moving more, but maybe don't quite know how to do it correctly. So they come up with some kind of injury, and then they come to see me, and we work things out, and then try to have a good network of trainers outside of discharge with my patients, and then really make them have a good my patients, that is, make them have a good transition back out to the gym or to the track or to whatever they might be doing for their activity.
Amazing. Okay. And you actually teach some chiropractic as well, is that right?
I do actually, yeah. I teach some anatomy and physiology at the college level, university level, and then I'm also teaching at the chiropractic school as well too, a palpation class actually. So a
Oh,
lot of
fantastic.
very much the definition of hands-on technique.
Yeah,
So
yeah, absolutely.
yeah.
So that's amazing. It sounds like you do with your clients, you do kind of a real blend of what could be considered rehab and kind of performance-based stuff, where you're maybe
Mhm.
trying to. I mean, I sometimes look at the two as pretty much the same. You're trying to
Yeah.
get somebody back to a higher level of performance where they've been, where it's been very detrimented, and then if you continue with that person, maybe you're trying to get them that little bit quicker or that little bit stronger. So um, obviously it's a lot of hands-on stuff that you've been doing. What initially attracted you to AMN after all that education that you've had, the kind of work that you do? What attracted you to what we offer?
Well, I have a very traditional, extensive training in what most people call traditional physiotherapy, just therapies in general, which has a very mechanical approach.
Hmm.
This is tight, this is painful, you attack that kind of thing, you stretch this, you strengthen this kind of thing. I started to get more and more into reading and learning about the neurological system, even outside of what I had already learned in school, and really taking that approach of there's an underlying neurological issue probably going on with everyone, because that's what's controlling our system, that's what's controlling our movements. So there was an old adage that I learned a long time ago that I stick with me, is where you think it is, it ain't, from Ida Rolf.
Yeah,
And
absolutely.
it really rang true when I was working with some colleagues, and they kind of illustrated that point, that a knee patient is not a is a knee patient because that's where they feel the pain, but that's not where their problem is. So through more study in neurology, realizing how much more effective I can be with that kind of application, I was getting better patient outcomes. And then honestly, I came across AMN on just a Facebook post. I think I was just moving through my timeline, and I saw that, and the words movement and neurology jumped out at me.
Hmm.
So I was taking a closer look at it. And like most things with me, is I try to get as much information as I possibly can before I really get into it and commit to it. But one of the most interesting things was exactly what makes AMN so unique, is it's dealing with the bioelectrical system.
Hmm.
There's nothing out there that I know of that really addresses this type of application with anybody, whether it be movement, whether it be, serious neurological conditions, anything like that. So it was incredibly unique. So I watched a lot of the videos that you did, David, and saw some of the results that you got. And I would mimic a couple things that you did in videos, and just see for myself how they worked on different individuals. And I was seeing some really cool results. And if I could see good results like that, imagine what could happen if I actually got into the coursework and started to delve a lot deeper into everything there. So it started to really explain a lot of things for me. I didn't really understand a lot of things before I started to study AMN, and it started to really clear certain things up. Um, it really started to kind of open up the doors that there's a lot more than just this person can't touch their toes. They can't fire a muscle through a muscle test or anything like that. It's expanding my applications, and it's opening up my toolbox, making my toolbox a little bit bigger to treat my patients a little bit better.
Very cool. And I'm glad you noticed that, that aspect of what we talk about. It really is something that I work very hard on trying to help to explain to people who get into our education, anyone who has any interest in anything that we have to say, that there is this entire system, bioelectrical phenomenon, and of course the subsequent electromagnetic phenomenon that occurs from electrical signaling in the body, that is kind of a big deal, right? As Will Ferrell once said, it's kind of a big deal. And when you learn how to work with that as a system that you can actually assess and then stimulate in a simple way, you can actually see the nervous system respond instantaneously in a way similar to what would be a more hardcore kind of neurological approach, where you actually drive a system neurologically and expect to see a different outcome from stimulating a particular pathway, doing a particular visual motor drill, or whatever it is. So there's kind of these two ways to attack this whole thing. And I'm really glad that you picked up on that, because obviously that's what we're all about, and you've obviously flown with it. So is there any particular cases that you want to discuss with us that you've had particular success on, things that you might think would be helpful to talk about for other people considering learning or that are already students?
Yeah, absolutely. I get to see a lot of patients that they come in with traditional musculoskeletal conditions, shoulder pains, knee pain, stuff like that, that I don't want to be disparaging, but they come in and they say, therapy has failed me. They come in, they said, yeah, I had physical therapy for this condition. Oh, how long did you do therapy? About 6 to 8 weeks. Wow. 6 to 8 weeks. Didn't get any better? They're like, no, it didn't. To me, that's upsetting to me, because I strive to get patients better as quickly as possible. And if they're lingering, there's something missing. So I need to do more. And, this is an approach that really helped with that. I had a patient that I've seen for a long, long time. She comes to me because, as she says, that you're the only one who can fix my shoulder. So I pat myself on the back for that kind of stuff. But she's incredibly active. She's 61 years old. She does karate. She swims. She rock climbs. She is a nurse as well too. So she's doing a lot of patient transfers, things like that. She has a partially torn rotator cuff on her right shoulder. She has bicipital tendonitis, chronic bicipital tendonitis, and really just some malpositioning of the joint. She doesn't have good glenohumeral joint centration. So every now and then when she gets into what she's doing, she has a flare-up. Her shoulder is incredibly painful. She has a lot of other gut issues and health issues too. So she has a lot of underlying, what did she call it? She called the colic inertia was the term that she used for me too, which is essentially very similar to diverticulitis, a close relationship. It's a term I never had heard before as well too. So yeah, I had to look it up when she told me that. So very close to things like diverticulitis and leaky gut as well too, probably more related to leaky gut. So she has a lot of underlying issues. And as I speak with her too, every time she comes in, she'll often tell me, oh, I can't do this because it hurts too much. And I start to see, there's an emotional quality to what's going on there as well too. So now that I've gone through all the coursework and I've done level 3, I can really use level 3 and attack those underlying issues with her limbic system and her gastrointestinal system too. So moving through the homeostasis screen, like everything, and we've talked about this before, everybody has limbic stuff coming up.
Yeah,
so
you've got limbic stuff, that's for sure.
Yes, everybody does too. So you drop it down and you find out, she's got some organ relationship, glandular relationship, to the issue that's going on, and also some personal conflicts going on that we found in the limbic screen. And I think hers were kind of blatantly obvious. She's very active. She wants to be very active. And when her pain stops her from doing that, she doesn't enjoy that. So I think that was a very clear thing for her as well too. So the limbic screen showed some glandular issues coming up. What was very interesting too is that one particular organ did show up on that screen. It was the small intestine.
Mm.
Then I go over to the gastrointestinal screen, and that's what actually lit up on the homeostasis screen for the GI. So her small intestine comes up. I go through the process, and I apologize if anybody watching this is not really following too much, but found out she has high histamine levels too. So talked to her about a little bit more about her condition, and sounds a lot like systemic inflammatory issues, a lot of stuff coming from the gut. She has a lot of issues with her gut, to the point to where I know there has to be some nutritional intervention, but when we can really calibrate the system, we saw really good results. And just with calibrating the homeostasis screen, we actually saw just improved range of motion in the shoulder, less pain, not zero pain, but less pain, much better and smoother range of motion, to the point to where when I first did this to her, she, because every time I had seen her, it was really just maintenance. But when I first did the homeostasis screen, she saw that improvement just after calibrating homeostasis. And she had that, oh, wow, shocked look on her face. Just, wow, that was great. That feels so much better. No pain. It was awesome. Or less pain, really. And then taking her into the neuroskeletal screen, really a lot of things coming up. This is the best part about AMN is it's a shoulder, but you may not suspect that it's the shoulder from what you learned through this. So through the neuroskeletal screen, whatever that word is, I found the lumbar spine was coming up with the touch testing, and actually the same side hip and knee were also coming up as well too. So through history, we discussed chronic ankle sprains, which was surprising that ankle didn't come up, but chronic ankle sprains, never really trauma to the knee or the hip. But she did say, oh, hey, is there anything going on in your hip that you forgot about telling me? Is, yeah, a month ago or so, I remembered I had some pain going on in my hip. Okay, well, that's something to address there as well too. And then jumping into the hip beforehand, because of its relationship into the shoulder, even when on the same side, we attacked it from proprioceptive file, cleared that out, and then really went into it with the ventral horn. So the things that we saw is a lot of lateral stabilization issues. So muscle testing for things like abduction of the hip, glute med, even looking at the adductors in relationship to that. No hold. She could not really hold any of the muscle tests there. No pain was coming up, but it's just she was not able to hold any of the muscle tests I was doing on her. So went through the ventral horn technique. Everything seemed to come up with muscle spindles. Maybe you can comment on that, Dave. Why would all be that? So it wasn't anything. It was specifically the 1 second spindle, or the fast spindle rather. So cleared that stuff out. Got the hip to fire a little bit better. Got some better range of motion back in the hip as well too. Went back and checked the shoulder, and actually was looking at joint centration, and it was so awesome to see that you could almost see that the ball of the humerus just kind of slide back in a little bit, very subtly slide back into position where it needs to be. So went through the range of motion in the shoulders, and she said it's even less pain than before. I feel like my arm is lighter. I can move through there. And I hadn't even touched her shoulder at that point too. So this kind of approach is so great, because it like further previous approaches that I'd taken, I got pretty good at, okay, you have a shoulder issue, but it seems from what I'm seeing to be your left knee. This is so much faster. So it got me through this process and attacking the actual problem so much faster. And then I can take what I found there and I relate it back to the shoulder. So for me, when I find the right hip and the right shoulder being an issue, I connect it through fascial lines, those lateral chains, and then I can start to really take that approach there. So she had a pretty interesting case, but I wouldn't say it's any of those really out there cases. I don't get a chance to see a lot of stroke patients per se or anything like that. I see a lot of people that they just have those nagging aches and pains and dysfunctions that don't necessarily get treated correctly with the therapies that are traditionally out there. And this really narrowed it down for me too. So just without even touching her shoulder or looking at her shoulder, better range of motion, less pain, much more functional. her mental capacity too, or rather her mental state got better too. You could see how happy she was getting just with
Yeah,
the range
that's a
of
great
motion.
thing.
So that attacks the limbic system as well too, when you think about it from a biopsychosocial standpoint.
Absolutely. That's a very cool story. And it's, I mean, you said a lot of things there that I'll try and expand on a little bit with people who might not really know what it is that we do. But one of the things you said is that you tend to deal with those kind of like niggling, nagging aches and pains that come in. But if those were just purely simple problems, most people before they get to you have been somewhere else. And if they were just basic biomechanically, okay, this connects to this and I treat this and that gets better and we're done,
Mm-hmm.
then those problems would have gone away. The point is that while you can have distinct mechanical relationships in the body, biomechanical relationships, if those exist, you have to also accept that there can be direct relationships between much, much more distant systems that you would never consider unless you have a method that allows you to screen and find out whether things are connected or not. So what you've described is a process where you've gone through in a hierarchical fashion, things that are important and pertinent to the neurology and the physiology. So you've started off looking at the limbic brain. You start looking at emotional conflicts and things that may be exacerbating a physical problem in the body from the reference point of essentially not quite emotions per se, but conflicts that arise from thought and feeling that cause some kind of disparity in the system between the brain and an organ and a part of the body. And then from there, you've gone through and you found other things are flagging up with which the assessment process is showing you on your behalf, right? It's doing it for you as you go through. You just have to know how to screen and go through and pull the stuff out. And then you've just built this picture out of where the dysfunction lies. And when I go through this process and it happens, I kind of take a step and you get one of those cool results like you've mentioned, like where the joint kind of recentrates and everything gets better and the person's really happy and you're like, everyone's high-fiving in the room. And you take a step back and I just go, wow, thanks brain. And I'm talking about the client's brain. Thanks for showing me, because I didn't have a clue. And I've met a few people over the years, doctors, chiropractors, sports therapist people who are clinically just incredible people with this immense knowledge and huge capacity to recall every single condition that walks in and what it means, et cetera, et cetera. I'm not one of those people. And I think it's fair to say that most people who go through, some sort of doctorate training or therapy-based treatment, they're not those people either. So I needed a way to be able to say, well, as good as you could be at diagnosis and differential diagnosis, the best it's still to a degree a guess. It could be a brilliant guess, but it's to a degree it's still a guess. And being able to just ask the nervous system, ask that bioelectrical system, okay, where are you misfiring? Show me. I'll give you a couple of taps on the head and I'll poke some spindles and I'll do some things and I'll maybe suggest that you think about this in a different way, and then how things get better. That's kind of what this process is all about, and that's what you've just described. So very, very cool, really cool for both of you. And also with someone like the lady you're talking about who's very allopathically trained, someone who works in the allopathic model, having
Great point.
like that happen is just that extra little bit of cool, isn't it? Because it's I'm sure there would have been certain barriers maybe towards the process and misconceptions about what it is you're doing and that sort of stuff. So cool that it was such a great response.
That's incredibly common. Yeah, actually, fortunately for her, she actually delves a lot out of her allopathic training. So I'm lucky with her, but I definitely have many patients who may have no medical or therapy training whatsoever there. And you can just tell they're kind of like, what are you doing? And it's just a process of trying to explain it to them. The better I can explain it means the better I understand it, to be honest with me, with my thought process too. Yeah. And you said the best thing there too is just you're asking the brain, and I can't remember if it was exactly your quote, David, or I know I got it from one of the manuals, is 86 billion neurons can't be wrong. You have to ask them, what's the problem? Because at the end of the day, and I see this a lot with my colleagues, is they'll be like, oh, today was knee day. And you get all these patients that come in with the knee, and you get that first knee patient of the day and you nail their diagnosis. But there's something that goes on in our brains that the next knee patient comes in, our brains start to tell us that looks a lot like that first case. That looks a lot like that first case. And you tend to start thinking, oh, it's probably the same diagnoses. And I mean, at the end of the day, that really is guesswork too. This is so much more accurate because it takes us exactly where the problem lies. So it's not to say that anybody is diagnosing incorrectly. It's just that this is so much more accurate and gives us a much better picture, and a little bit faster too, because like I said before, is I could get pretty close, but it takes a little bit longer time to, go back and forth, moving the patient around, making sure that their movements are crisp or they're improving with the interventions. And this just gets you there, in no time flat.
Yeah, I mean, that's the thing, right? I mean, the role of the mind essentially is to ultimately make us feel that we're right. That's essentially what the mind does. And it wants to predict, it wants to utilize past experience and predict what's going to happen so that you can have a better sense of feeling that you're right, essentially, which is the process that the brain's always going to try and take you through. And it's going to want to try and find patterns. And I found when I try and let go of that as much as possible and just go, okay, cool. Thanks for all the information. Do some orthopedic tests, watch the person move, and I go, okay, cool, thanks, take a seat, let me see what 86 billion neurons think about it, because I've got some ideas, but hey, I know nothing in comparison to your nervous system. So and that's that's the process in a nutshell, right? So it's a very cool story. Is there any other stuff you wanted to mention case wise, or?
I think that's probably the best case I've had so far. Is
it's a hell of a good one.
Yeah, well, I mean, everybody else kind of gets cleaned up very quickly. Some of them are less eventful, I would say too. Is clear out limbic system and then kind of nail down with the neuroskeletal screen. Where we're dealing with is, I guess, I could be fortunate or maybe unfortunate that I don't have a lot of those awesome case studies, but I do see a lot of people, very clear cut stuff. That's the other thing too to point out is someone comes in with shoulder issues or elbow issues. They're clear out the homeostasis issues. A lot of times for me it has been limbic and GI that seems to light up for most people. Every now and then, which surprised me because I thought more people would. The osmolarity screen, people are dehydrated. But when I go through the neuroskeletal screen, you get very clear-cut issues. I had somebody in the other day. It was a elbow patient, and limbic, some small. Actually, GI did not light up. It was just limbic, and then it was neuroskeletal screen came up. It was cervical spine. It was that exact same shoulder. It was the opposite side cortex. Everything fit together very nicely for that case presentation. It wasn't anything you go, oh, that's interesting. It was right elbow, so it was left cortex. It was the cervical spine, and then, just went into it and attacking it with the ventral horn, and it was muscles that were around the elbow and did move the elbow as well too. So
there you go. Yeah, absolutely.
Yeah. But it makes those cases so much easier to kind of just very smoothly go through.
They're just a relief sometimes when people come in and you go, oh, this is so straightforward. That's cool.
Yes.
So you just treat, what you would expect there, and it works out quite nicely. Well, that's, you're doing great stuff out there in your clinic. It's really cool for me to be able to put this information out there, having worked on this system and in this system for so many years. And I do less client stuff now. I tend to work with the specific cases that are things that are really, really complex, to try and challenge myself to evolve the process a bit more, which I'm trying to do. So it's great to have people like you in our community who are out there helping so many other people, because that's really what it's about. So I really appreciate the work that you're doing. So how could people in your area get in touch with you to come and get a treatment with you?
You can go to my website for my clinic. It's www.mykinetichealth.com. So MY Kinetic Health. That is the name of my practice, is Kinetic Health. Chose that for a reason. We fix your movement, basically. I can also be reached on social media. It's at my Kinetic Health on Instagram, or at Dr. John Campione on Twitter. So at Dr. John Campione on Twitter. Any of those formats, best way to get it. You can even go onto the practice website and schedule an appointment right there.
Amazing. Well, anyone watching this who knows someone, or knows someone who knows someone who needs help with pain, if you're in that area, check out Dr. John, because he's one of our best. And I hope you get some new patients out of this. It's been a pleasure speaking with you, John. I really appreciate it as ever.
You too, David.
And maybe we'll do it again at some time in the future as well, with
absolutely
some more crazy stuff that happens through this system. So thanks very much for your time.